Good morning, everyone. I want to congratulate you all, first of all, for being so docile and patient through a very long morning. And I'm going to take a minute or so to set the context about Kaiser Permanente. And if you want to, if you feel the need to, stand up and stretch a little bit while I'm doing that. Please go right ahead. You've had a long morning. I'm also very aware that the only thing between you and lunch is me. And so I promise to be as entertaining and as brief as I possibly can, which is not an easy thing for me. I want to thank, first of all, Sitra for having me here. I was here once before, and somehow they managed to want to have me back, and I'm not really sure about their judgment, but that's another story. Particularly, I want to thank Timo Heikkinen, who's always been a very diligent worker on the part of Finland and of Sitra in the United States, talking to many, many people, scouring the land, if you will, looking for important object lessons to bring back to Finland. And you should all be very proud of the work that Sitra does and that Timo has done in particular, and give them a round of applause since this is their conference. So what is Kaiser Permanente? As Hanno said, we are a large integrated healthcare delivery system. We take care of 8.5 million people. There are 12,000 physicians like me in the Permanente medical groups across the United States. We have operations from Hawaii to the East Coast, primarily in California, but in many different geographies. There are 430 medical offices ranging in size from 2 or 3 physicians on the small end to greater than 100 physicians and all sorts of specialties on the large end. We own and operate 32 hospitals, and we have contracts with other hospitals in the communities in which we do business in order to render care. We own and operate our own pharmacies. We're the world's largest non-governmental purchaser of pharmaceuticals. We own and operate our own laboratories and our own imaging systems, a very highly integrated healthcare delivery system. That is what we are. We are also on a journey, and I'm here to talk with you about that. I will also tell you that I'm not going to show you features and functions of our system, and I'm not going to demonstrate aspects of it that relate directly to some of the issues that you've heard about before. That's already been done very ably by certainly Dr. Fletcher and other speakers that you've seen. It's not about the specific features and functions of the technology. You will find your own path in that regard. It's about changing the culture and the way that healthcare is delivered in Finland. That is what really matters. Just so you understand, we have had healthcare information technology systems in Kaiser Permanente for many, many years, more than 20 years. And what we are in the process of doing now, what we call our KP Health Connect project, is removing many of those older homebred systems and replacing them with a single platform across the entire nation. We began that process in earnest in 2003. By the end of this year, roughly 70% of our physicians will be using our product on an ambulatory basis. About 15% of our hospitals will be covered by the product as well. All of the business side of the systems will be fully replaced. Scheduling, discharge and admissions and transfer applications, billing, and so on. All that will be done by the end of 2005. So we've made a lot of progress. We expect to finish this phase of the project by and large by the end of 2006. There really are no obstacles in our way at this point because, as Dr. Fletcher mentioned, once you put this kind of tool in the hands of physicians, there is no going back. You reach a tipping point, they want it. That's not the issue. So I thought a hockey metaphor would be useful for Finland because I know that you have lots of hockey players here, and hockey is an important sport. How many of you know who Wayne Gretzky is? Just to see. Lots of people in Finland know who Wayne Gretzky is. That's good. And so you may even know this quote. When he was asked why he could score so well and was such a prolific scorer, he said he tried to skate where the puck was going to be. Tried to skate where the puck was going to be. So my talk is about anticipation and understanding for yourselves and for Finland how to do that. And by way of example, what did Kaiser Permanente do to understand what the target was like? Where is our puck in healthcare going to be? And what are we doing to skate to get there? So we call that the blue sky. Blue sky is an idiom in American colloquial English that makes reference to sort of a very expansive idea of what the future might be, a blue sky vision. And what we did was to bring what we hoped were very able thinkers. Now, it included me, so you might not think they were all able thinkers, but we brought in people who were really smart from outside of Kaiser Permanente and from around Kaiser Permanente. And it included physicians and nurses and public policy experts and industry experts from technology and politicians and so on, about 60 people altogether. And we asked them a question. This was done in 2002. What will healthcare in the United States be like in a little over a decade, in 2015? We just asked them a simple question. And we chose that date because it wasn't so close that it would be very predictable and very familiar, and yet not so far away as to be a silly exercise because it was too hard to predict. And what we did was a lot of fun, actually, for the people who were involved. We made them write little plays. We made them build scenarios, and they actually acted these skits out for each other. And there were skits about chronic illness, patients with chronic illness, patients who were young and healthy, patients who were pregnant, and so on. Little plays. We have the videotape, so if any of them want to renege on their ideas, we can just show them the tapes later. And what we did after that was to try to distill the lessons from these skits and give those lessons to about 4 dozen senior operational leaders from our organization and said, here, this is what the futurists think the future is going to look like. What do you think we should do today, tomorrow, and over the next several years in order to build Kaiser Permanente to be able to meet that future? So we heard the health minister talking about the strategy for Finland. And I'm hoping, that what's been happening is that the Finnish people and their leaders are trying to imagine what the future holds and setting a strategy to get there. And we heard Esko also give some statistics about the demographic time bomb in Europe. And we have a similar one in the United States. The median age statistic is a little deceptive for the U.S. because we have a very different population curve than Europe, but it's still kind of threatening. There is so much in-migration to the United States, even though we try very desperately to stop it. There is so much, and those immigrants tend to have such large families that there is a bubble or a balloon, if you will, of very young immigrant families driving the median age in the United States down. If you look at the non-in-migration population, we are aging about as fast as Western and Central Europe is. So the fact that the median age in the United States isn't going to change over the next decade or so is a rather deceptive statistic because we have an aging population too. And there are a great many more people who are going to be over the age of 65 in the years to come than there are currently today. We are getting fatter. And there's not much to say about that. Very obese, lots of healthcare burdens imposed by obesity, many more chronic illnesses. 5% of all adults in the United States over the next decade will be survivors of childhood cancer and all the poisons that we throw at them. That's a little known statistic, which is kind of frightening. And at the same time, we have, as you have, a decreasing number of nurses, decreasing numbers of physicians that we call primary care physicians. These are the doctors who deliver care in a primary way to adults and children. Most of them in the United States are internists or family physicians. We do not have very many general practitioners anymore. And we don't pay them as well as we pay all the other doctors. The reimbursement for physicians who charge fees for their service, which is the bulk of care in the United States. It's not what's done in the Veterans Administration. It's not what we do, but it's what the bulk of physicians and healthcare in the United States do. Those reimbursements are dropping for primary care doctors. And the healthcare costs are rising, both as a proportion of GDP and just as in absolute terms. The dollars are staggering. So we built a model, and you have this picture. I'm not going to ask you to memorize it. I'm going to elaborate on these themes over the next several minutes. But this is what the skits drove us to. The patient is in the middle. Now, it's very convenient because we often say that everywhere in the world, and certainly in the United States, that the patient is at the center of our system. But most of the time, that's the patient as a kind of a target where we aim things at the patient, and they're either dodging them or catching them or something, but they're a target. What we mean is that the patient is in control, and I'll talk about that in a bit, because it's very different and actually quite frightening to most of the doctors and nurses who hear this discussed for the first time. Now, home, we think, is going to be the hub. You heard some very exciting things from Dr. Fletcher about what the Veterans Administration is doing to empower veterans to do things for themselves in their homes. If you think about it, this is the wave of the future everywhere. Most patients, although we'd like to think differently, don't spend all of their time with us. They spend most of their time not with us, even the ones that are very ill and come see us very frequently. If somebody comes to see you, how many people here are physicians or nurses? Raise your hands. Any? So you have patients presumably who are very, very frequent visitors. Let's say someone who might come every week or every other week and spend 15 or 20 minutes with you. That means over the course of a year, they might spend 4 to 6 hours with you. The rest of the year, they're on their own. And that's the sickest person. So home is already the hub, we just don't recognize it. Secure and seamless transitions, I'll elaborate on what that means, but basically it means moving the patient through sites of care or people doing care without them having to be the navigator and make the transitions and move their own data. Customizing, and then finally integration and leveraging. So let's talk about these. Home is the hub. Self-monitoring. People need to be able to monitor themselves, whether they have important chronic illnesses or not. They need to be able to monitor themselves, and they need support to make decisions. If you have asthmatics, you want them measuring their own peak flow, and you want them to know what to do if their peak flow is outside of a range that's healthy for them. You don't want them to have to depend on you for every decision. They don't want to depend on you for every decision. The care team needs to know if the patient has done something, just as the care team in Dr. Fletcher's example knows when the patient has weighed him or herself and has made some adjustment to their exercise or to their diet or life routine as a result of their weight. The care team needs to know what's going on, but only has to have attention drawn to it if something is wrong. There's going to be a lot of data here, and it's really a bad idea to bury people with data. You don't want the doctors and nurses in Finland to see every glucose measurement that every diabetic in Finland does. You want them to see the ones that matter, that are a risk for the patient, and to be assured that those are that all the others are happening. And again, the office visit is not the core of our responsibility or the core of our activity for primary care doctors anymore. What we think is that systems have to deliver decision support tools for patients and their families, what to do in certain situations, and in fact, when to contact or interact with their doctor or nurse. And then sort through and prioritize data and give important horizontal views. You saw the power in the VISTA system of graphing. Very simple tool, but showing things longitudinally so that doctors and nurses can understand trends is actually rather novel if you think about it. In the paper record world, it almost never happens. They're seeing things in the moment, the laboratory tests for today, the vital signs for today, not an important view of information longitudinally, which really changes how you view the patient and what judgments you make. And allowing for intervention at the population level, whatever you use to define the population, to do something for all the diabetics in Finland, to do something for everybody who needs an influenza immunization in Finland, to do something for everybody who needs to lose weight in Finland, is the population intervention. Now, right now what happens, at least in the United States, and I'm unfortunately woefully ignorant of the details of the healthcare delivery system in Finland, but I imagine it's similar, is if a patient comes to see a doctor and they're felt to need a consultation, they're told to go get that. So you have to see a cardiologist. Here's the number you call. Please make an appointment to see the cardiologist. Under most circumstances in the United States, the cardiologist may be contacted, but they have no information as to why the patient is coming to see them. And they put the patient through a bunch of repetitive things and hoops in order to sort of build the case for, well, why do you need a cardiology visit in the first place? I didn't hear much from your primary care doctor. I'm suggesting that the system has to behave differently and may even suggest a transition from primary care to cardiology care with a trigger that's independent of the primary care practitioner, so that the patient does something, has a test, and it shows a left ventricular ejection fraction. That's what that acronym stands for. And it drops below a certain threshold. And that triggers a referral for a cardiology evaluation because that's an agreed upon step for that particular patient. When your LVEF falls below this level, what we're going to do is we're going to have you reevaluated by the cardiologist to see if there's something else we need to do. And it will suggest what additional tests need to be done before you ever get to that cardiologist so that when you do, the cardiologist is prepared with all the information they require to make reasonable judgments for you, and you know why you're there, and they know why you're there, which is very different from the way things happen today. And all of that will happen without any steps necessary on the part of APC, stands for Adult Primary Care Practitioner, unless they know something about that patient that causes them to redirect, to make a change, and then they can do that in an active way. That's my view or my imagining of a seamless and secure transition for a patient who might be getting into trouble because their heart failure is getting worse. Okay? And the other thing that happens is that very often the primary care team has to remember all the rules. Cardiology wants to see patients with certain conditions and certain issues, but only on certain days and only in the afternoons. And you have to call this number, not that number. And by the way, next week we're going to change all of that and have different numbers for you to call on different people. But it depends who's on call because they may be kind of crabby today and tell you to do something different. All of those navigation rules we now make doctors and nurses try to keep track of and remember today. And that's a mistake. We can build them into the system, and we are already doing things like that, and that's extremely helpful. It makes the primary care operations more efficient and more effective if you do that. So that's what secure and seamless transitions are about. Customization. We want the patients to exercise the degree of control over their care that they want. They will choose how they want to be communicated with. In Finland, they may want text messages. Maybe all of you are carrying around those marvelous little Nokia phones that you can flip open and have instant access to the web because that's just what Finnish society is doing. And maybe that's true even in the most remote of your municipalities. And maybe everybody will choose that. But you at least can give them the choice. Do they want text messages? Do they want internet messages? Do they want telephone calls? Do they want letters? What do they want? How do they want to be communicated with and under what circumstances? The system can know and understand that. You can customize the system so that it allows for that kind of personal choice. And you can, using the kind of centralized data warehouse that the minister was suggesting, essentially devise a life care plan for every citizen. You can say, based on what we know about you, about your age, about your sex, about your physical characteristics, about your medical history, your social history, your job, based on what we know about your purchasing. Because I don't know about Finland, but in the United States, all of us have these little cards that the big grocery chains give us, and we use them because we get a 3% discount. Do they have that kind of thing here? Yeah. And what did the grocery chains use that for? They know exactly everything you buy. Everything you buy. If we wanted to, we could this is getting to be pretty scary for the patients, but we could actually purchase a database that described at least their food purchasing habits. And we could meld that into this healthcare data, because that's a form of healthcare data, and create a care plan that says, you know, you're going a little heavy on the prepared foods and the cheeses. Maybe you need to figure out how to change your diet, and we can have a nutritionist do that for you. I'm not suggesting that that's part of our plan, but it's the kind of information that you can collect that's readily available today that you could build into a life care plan as part of customizing healthcare for every single individual. If we can do it for 8.5 million people, you can at least contemplate doing it for the nation of Finland. And I think it might be something that the people of Finland would value, to have their own plan for themselves about what they can do and not do to manage their own health risks. And you can do things that seem like mass communications but are individually customized. And here, please excuse me, I've referred in this one particular case to a discrete function within our system. It's a kind of phrase that as a shortcut to inserting all the laboratory values for that person into a document, like a letter to them. So if you make the document using a format, you can view it as a macro, and you're writing a letter, and it's the same letter in structure for all of the diabetics, but you put this little macro in there, and it pulls in the laboratory results for that person. And they think, oh, I've gotten a personal letter, because they have. They have, but the machine can do that for you. And finally, and this is very important and it hasn't been tapped, we have the capability on our internal website, which is much like what the VA has, although not quite as far along in terms of its deployment, to create questionnaires that people can fill out before they come to see us. We certainly do that for health risk appraisal today so that we can build them that life care plan. But what I'm talking about is a visit questionnaire that's targeted for a particular visit. So if you're going to come see me as a pediatric infectious disease clinician, I would ask you certain questions, and I'll do that in advance. It'll help me prepare for the visit. It'll help you target what you want to do and accomplish during that visit, and it'll make the whole experience more efficient and more customized for you. Integration and leveraging. So remember, I said that we're not going to have as many primary care doctors as we've got today. We need to figure out how to make them more effective. And by the way, it wouldn't be bad to make them happier so that they would stay in their jobs because we need them. So that's an offshoot of this kind of work as well. We want to support them better. We can turn other staff loose on tasks that are really not necessary for physicians to do, and focusing very intensely on what is it really that doctors need to do, that they and only they are qualified to do. What is it really that nursing staff and only nursing staff can do? And then figuring out how to divide up the work and the tasks involved in healthcare and allocate them in different ways than we have. Because if we don't do that, we're going to continue to drive people out of primary care because they're unhappy and the work burden is so enormous. We're going to have to, in the United States at least, change regulation. We have licensing laws that differ from state to state to state that do or don't allow nurses and doctors to do certain things, and pharmacists and other trained, intelligent professionals that need to be addressed in order for us to really make efficient use of people and their skills. So that's a task. We'll turn the attorneys loose on that one. And finally, what we want to do is change the way the primary care doctors look at their world. Their world mostly has been driven by the urgent, the person who is immediately in front of me. To a degree, they still have to take care, of course, of that person who is immediately in front of them. We want to give them the capacity, the skills, and the support necessary to manage an entire panel, a group of patients for which they are responsible. You see what happens when you do that for physicians and you give them data about how their panel is doing in the kind of data that Dr. Fletcher reflected earlier this morning. How are my diabetics doing? What can I do to take care of them? If you give them tools to take care of them, they will do better on an individual basis and on a population basis. That's taking advantage of them, leveraging their skills. Now, I said the panel members, the patients are in control. There is a metaphor that's commonly used in the United States, at least, to describe doctors and nurses who are doing primary care. They are often referred to as individuals working in the trenches. I don't know if that's a common metaphor here or anywhere else in the world. I detest it because, of course, it's based on an analogy to World War I, when what was happening is that people were in these vile trenches with an ankle deep in water, with typhus and poison gas being lobbed and barbed wire, and this horrible, disgusting situation when it's as if the patients were going to come over the wire and attack every day, and you had to do things to force them back. That's what people feel like in primary care in the United States. And we a lot of times devote our resources to sort of helping them make war on the patients. And we need to stop talking about the patients that way and stop making war on them and turn control over to them, letting them do simple transactions. I've used this question in other settings here, but perhaps most of you haven't heard me talk before. I'm assuming all of you do air travel at some point. How many of you use the internet to make your bookings now? If you look around, literally everybody in the room. Do you find that you're not capable or smart enough to do that well? No. What do you think happened to the first person in the airline industry who suggested that they turn over the bookings to the flyers? They were probably fired. because it would be too complicated to let passengers do their own bookings. They will get it wrong, won't they? They'll go on the wrong flights to the wrong cities. They'll just get it all wrong. Well, of course, in retrospect, it's easy to see that that wasn't true. And now, of course, the airlines are driving people to do it that way. But we all like it better. And look what they've done. They've taken cost out of the airline business. They don't have to have nearly the support or the clerical staff to do all the bookings. Travel agents, as middle people, have been made people of the past by the internet. We do it all ourselves. We're doing all this work that we used to have somebody else do, and we think it's terrific. We think it's great. We're all much better off. We're in control. That's why. We can manage it ourselves when we want to manage it, how we want to manage it, and that feels better, which is why we avidly do it. And we need to do that in healthcare too. There is absolutely no reason why all appointment making cannot be turned over to people given the right tools. That's going to make everybody in the room, if you're not experienced with that, shudder. We do that today in Kaiser Permanente. Not for the specialists, but for some, but certainly for all the primary care. And we'll get to the specialists. The reason it's not for the specialists is because they're just more powerful and more worried. They can certainly look at all their laboratory results themselves. We don't need to be the ones who are the keepers of that. They need to have their results interpreted, but they don't need to have us be the ones who are the gatekeepers for whether or not they can actually hear about what the results are. They can see those. We can give them guidelines so they can take care of their own illness. Why are we the only ones who can have guidelines and evidence-based medicine? They can do that too. And we can allow them to communicate asynchronously, which is much more efficient. The internet here is going to be, and already is, being extremely powerful. And then, when we don't have to devote resources to these functions anymore, because we've turned them over to the patients who want them anyway, and can do them better than we can do them, we can use them for the things we need to be doing. Managing the communications properly, doing panel management, and taking care of people who will not participate, the outliers who don't choose to message, who aren't well adherent to medication regimes or to guidelines. So, an electronic health record is helping us reach for the blue sky. And I want to talk about why we would make that choice and tell you how we made that argument and that case inside of our organization, and then go on from there to conclude. So I'm going to answer briefly what the economic case for an electronic health record is, what are the likely improvements in the quality of care, what are there savings that can be accrued from enhancing patient safety using an electronic health record, and how can you measure these effects? How can you measure the pre-electronic health record system, which is actually the biggest of the two problems, because there's no data in the non-electronic health record system or a paucity of data that you can use to understand what its performance is. And then how can you measure the discrete effects of an electronic health record as opposed to all the other things that are changing inside of healthcare? So, what's the economic case? As Larry Smith said, money to invest in healthcare is sought by lots of competing projects and priorities. My organization has roughly a $30 billion a year budget, $25 billion euros per year. That may seem like a lot of money. It certainly does to me. You know, a billion here, a billion there, pretty soon it adds up to real money. That's not original with me. A man named Everett Dirksen said that. But anyway, yet we spend 95% of that every year, 96% of it actually, on delivering the care that year. So we have a small, thin 3 to 4% margin to do other things with. And there's a lot of competition for that margin, and an electronic health record is just one of the possible things you could choose to do. So why is it better than the alternatives? Speaking from the perspective of a chief financial officer who says, I've got all these competing things to do with the limited amount of money that I have, why is your thing the thing I should choose? What's the return on the investment? Got to speak the language that they talk. So we did this. We developed a case, a business case for the electronic health record, and I would say that anybody who's seriously considering doing this needs to try the same kind of exercise. That includes all the costs, the total costs of ownership for a decade, or whatever large time horizon you want to pick. And what are the costs of ownership? Well, most people remember to include the cost of the software, whether you develop it or you buy it, and the cost of the hardware. People start to forget that there's a lot of training involved, and they don't take those costs into consideration. They definitely forget there's an enormous amount of change management, getting people to do something different, and that has an enormous cost associated with it. And they forget that actually they have to take care of all this over that whole decade. They don't just do it once. They have to pay for it over time. And then they have to pay for something that goes beyond just simply installing it, but helping people to use it more optimally, more training, more change management. So the total cost of ownership, you have to really, really think hard about. Equally important, there are cost savings. Although we had an interesting, I was being provocative at dinner last night, you can create efficiencies, we think, using an electronic health record. It can generate savings. The problem becomes in trying to sort of see if you can make health care less costly by putting an electronic health record, because there are so many other things driving up the cost of health care that even if you generate discrete savings with an electronic health record, the total cost of health care will still rise. It just will not go up as fast or as much as it would have if you didn't do it. So if, in the United States, if I'm trying to explain myself to large purchasers of care who pay our premiums, they want to know when their premiums are going to go down. And I say never. It's just not going to go up as badly as it might have. And then you give accountability to the elements in the business case once you've created and say, okay, this is what we have banked on. These are the reasons why we're doing this. You, Timo, you are accountable for making sure that the training goes well, we spend the money on the training that we thought we were going to spend, and that the people emerge from that training with the proper understanding of the use of the system. And you are responsible for helping them optimally use the system. Making accountability is a very good thing to do. What are the likely efficiencies? This is a list you could all make, those of you who have had any work to do in this field. There's definitely reduced rework, fewer repeated tests and images, lots and lots of rework in the healthcare system today because of the way we do things. Almost all of that disappears. It's quite remarkable. Our experience of the file room devoid of paper and the people is absolutely consonant with the Veterans Administration. Within 6 months after full deployment of electronic health record, all the paper can go away, except for some archive someplace in case you need it for the future. So you use the principle, write once, read many. Take one piece of data that you need, that patient's age, and it's amazing how many times we make, in the paper world, we make people write down the person's age on successive forms, right? Try to imagine stopping that, stopping all of that, and just using that piece of data once entered many, many times because it's been validated. You can pool nursing work, for example. You can make them much more efficient by pooling message handling and pooling other forms of work if regulation will allow you to do that. Will allow you to do that. You can do something that we call virtual consultation. I can't tell you what the power of this is, and here's how it works. If I'm doing general pediatrics and I have a patient who comes to see me and I think they need to see a subspecialist, what I will do is contact the subspecialist right then during the visit, and they will open up the electronic health record at the same time that I have it open with the patient present. And we're all looking at it together and talking on the phone, and I'm describing the problem, describing the situation, describing my questions. Patient's listening. And they say, yes, I think that they need to come see me. And here are the things that I'd like you to do before they do. The patient thinks you're all wonderful because now at least two heads are thinking about them and not just one. They've heard the process. They realize people are focused on them and paying good attention. And it's been made more efficient for everybody. The consultant knows they're coming and they know why. They know that the data that they're going to need to make better decisions are already going to be available. And in some cases, you can obviate the need for a visit with a consultant altogether. They will say, do this, this, and this, and if the situation doesn't improve, then call me. And it's very powerful. It works beautifully, and we're doing it all the time, simply because you can open an electronic health record in more than one place at the same time. E-visits, we're just going to start to scratch the surface of. These are protocol-based visits that patients conduct using questionnaires over the internet. We haven't done it yet, but there's lots of possibility and potential for efficiency there. I already talked about pre-visit questionnaires, and I've talked about population management, and so did Dr. Fletcher, so I'm not going to elaborate on that further. We know that we can reduce adverse drug events. We can quibble about the numbers here, but we know we can make adverse drug events go away. We also know, by the way, we can introduce new kinds of adverse drug events, and we have to be careful not to do that. And we know we can improve primary and secondary prevention. In Kaiser Permanente, we have already, using systems like the ones we've built into our Kaiser Permanente Health Connect system, we have already dropped coronary disease mortality so much that it is no longer the #1 cause of death in our membership. Cancers are. That is not true for the rest of the population in the United States. So we can make, with systems like this, primary and secondary disease prevention, very good. Nothing falls through the cracks. Data is not lost. Patients are not lost to follow-up because of all the closed loops inside an electronic health record system. And because we can improve our capacity to measure, and this is why I got started in the first place, to measure clinical performance and the quality of performance, we will improve our ability to improve quality. And here I'm quoting a surgeon, an expert in quality management from the United States, actually from the Intermountain Healthcare System in Utah, a man named Brent James, who says, in order to be provocative, he does this to audiences of physicians, surgeons, because he's a surgeon. He says, I don't care, and close your ears, Larry, I don't care if you get it right. I care as long as you get it the same. His point is, if you at some point can standardize a process of care that's amenable to standardization, much like what Larry Smith talked about for certain forms of delivery, if you can get people doing it in a standard way, you can measure the outcome of a standardized process. That measurement becomes a more reliable measurement, and then you can do an intervention to improve, and you actually have a prayer of seeing something change. So standardizing when you can and then intervening is going to be very important, and it's only possible with electronic health system record systems like these. We have some data. Some of it is quite early, and I'm not sure that it's going to hold up, but I believe most of it will. Within 18 months after you finish a system, installation of a system like this, what we know is that outpatient visits fall. Not because we were trying to make them fall, they just fall. You don't need them because you're not doing the rework. And they fall in both primary care and specialty care departments. Now, that's not good news for most of the United States, because when visit numbers fall, in most of the U.S., doctors lose money because they bill for those visits. But it's music to Dr. Fletcher's ears and mine, because we run closed systems that are prepaid. And if you can reduce the visit burden, you can be more efficient with the staff that you have on hand. And I imagine that it would be very musical here in Finland as well. Laboratory and imaging utilization also fall. All that rework goes away. But it doesn't last. They don't stay down. They start to go up, and the reason is the technology is changing. There are more images that can be done. There are more tests that can be ordered. And so the rate of change over time hasn't been influenced by an electronic health record, but the absolute comparative utilization of laboratory and imaging services is lower in our system and in systems like it than in systems without electronic health records. Here's an interesting fact. If a patient thinks that the doctor likes the electronic health system that they're using while the patient is there, then the patient is much happier with the result of that visit, by a lot. And the reverse is also true. If the doctor is muttering about the computer and banging at it and saying, damn computer, it's just in my way, if they don't like it, then the patient is much less happy than average with that visit. Hospitalization rates, and this was found in the Veterans Administration as well, hospitalization rates drop like a rock. Emergency department visit rates drop. And it isn't because of queuing or denial of care. It's because of making sure that patients don't actually need that hospitalization. It's earlier intervention manifested by the kinds of techniques that you've seen here this morning. And malpractice losses. This is not guesswork. We don't, in Kaiser Permanente, we're so large, we don't actually purchase malpractice insurance. We don't pay premiums. We self-insure. We pay for the losses as we go. And so we know exactly how much money is lost for malpractice every year. Our losses and this was in the region of Kaiser Permanente where I spent most of my career in Colorado. Our losses were already lower than the rest of physicians in Colorado for a number of reasons, but they fell by 50% within the 2 years after the implementation of the system that we had there. And there are a number of very specific reasons why that happened, but it's held up over many years now. You have a safer system, you have a clearer system, and so on, and the losses from malpractice, if that's an issue here, will fall. We also know a little bit about emailing between patients and physicians, and we know that that reduces phone traffic, which is vitally important because phone traffic is very hard to manage. That's synchronous communication, means you have to be able to meet demand exactly when it happens, and it's very hard to do. It's very hard to do it in a way that satisfies people. Phone traffic falls, and doctors are very afraid of this tidal wave of emails that are very lengthy with all sorts of spurious and crazy questions. That doesn't happen. The average number of emails per physician per day is about 4. Very manageable, and the phone traffic has fallen to them, so it's actually not an incremental task, it's a changed task. And they can do those email responses in a more leisurely, measured way using the record to help them do it. So, what electronic health record should you choose? What should you do? Well, you have a bunch of gross choices. You could build your own. We did that, and we stopped doing that for a number of very specific reasons. You can adopt or adapt it from the public domain. VISTA is the system that the Veterans Administration has produced and made ready for use outside of the Veterans Administration. And you can do that. The software itself is free. Putting something in, the total cost of ownership of VISTA ain't free, but it's a little bit less costly because you don't have to pay for a software license. You could, within each category of aspects of the system, buy or license the best of breed. So you could find the best pharmacy system and the best appointment system and the best documentation system and the best order entry system and the best OB system and on and on. You could identify all of those and then integrate them. When you talk to engineers, they will tell you absolutely that they can do that. If you want me to integrate, absolutely, I can do that for you. It's very hard to do. Believe me, it's very hard to do. And from my own experience, and you can tell by the way I'm presenting this, I'm not unbiased. I have a bias in this direction. I think it's a really bad idea. And you're much better off buying a suite of, or engaging a suite of systems that all naturally operates off the same database without trying to integrate it ex post facto. You'll be better off if you do it that way, if you can. And that's the last choice. So, and the reason why that works better is because it's built around a single data model, and everything hits against that data. You know about it. As you move forward in time, the maintenance costs of that are much, much lower than a system that integrates best-of-breed applications. So, the leader has a very important role. You have this role. If you're not prepared to do this, I suppose you can go to lunch early. And then not come back for the afternoon, because it's crucial. What leaders are going to do is crucial. First of all, and most important for the rest of the nation, is articulating the vision. What's going to happen here? What's the clear story for the people of Finland? Where is healthcare going? How are you going to use technology to meet those requirements? How are you going to support the healthcare workers in Finland as they work to learn their new reformed system and to use that new technology? And then it's not enough to do it once and publish a document. You have to get really good at doing it over and over and over again. I'm a leader, and I'm not saying this just to be sort of self-congratulatory. I have been at this in my organization since 1987. And if I had stopped articulating the vision in 1987, first of all, I certainly wouldn't be standing here before you, but secondly, we would have perhaps failed if somebody else hadn't stepped in to fill in the vacuum. You have to keep the vision in front of everybody. You have to keep repeating it, and that's the leader's job. Then it really helps if you understand a lot about change management. There are theories, there is data here, there are ways of understanding how to engineer change in a system, any system, and certainly healthcare. And so you will become, if you use the parlance that we use in Kaiser Permanente, a sponsor. You will become a person whose job it is to understand how to change the part of the system that's within your span of control. You will allocate resources to do that change. You will remove the barriers in the way of people who are trying to execute on that change, and you will resolve conflicts that naturally occur when difficult change is being undertaken. That's what a sponsor does, simply. But it's much more complicated than that, and you need to make a study of that. So what's the epilogue here? Remember Wayne Gretzky. First, the vision. Where's the puck going to be? And second, maybe you have something to say about that. Where do you want it to be? But you have to decide that together and then skate to it. And I'll stop and entertain any questions. Thank you.